Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. We've got a free 31-page PDF. It's a great study guide on the top 200 medications. I lay out some of the most important things that you're going to need to know for clinical practice, as well as things that often come up on board exams. So go check that out. Great little review or refresher for you there. All right, so let's get into the drug of the day today, and that is gentamicin. And for purposes of this podcast, I'm going to primarily focus on systemic. Most of the times we're going to be doing IV administration inside a hospital or in an institutionalized setting. Potentially some outpatient IV therapy and stuff like that too. But that's really going to be my primary focus here. So primary uses of that injectable gentamicin, usually it's fairly severe infections, but in situations where maybe we don't have many options or there's tons of resistance or something like that, you may see this medication utilized there too. So urinary tract infections, meningitis cases, sepsis, in those severe situations, life-threatening situations, it's generally going to be used as add-on therapy in empiric cases where maybe we can't utilize another agent or we need to cover certain bacteria. There are a few other usages that are of note, I guess. One I guess I wanted to mention was gonorrhea. It is kind of a down-the-line option if patients have intolerances to some of the main drugs there. It has been shown to have some activity against that type of infection. Mechanistically, how does gentamicin work? So it binds the 30S ribosomal subunit. It's classified as an aminoglycoside. By binding that 30S ribosomal subunit, this inhibits bacterial protein formation or synthesis. And ultimately, that impacts the cell membrane formation. Dosing with this medication, this is definitely something that comes up in clinical practice, may even show up on board exams periodically. So the dosing for gentamicin starts off as weight-based when you're determining an initial dose to use. Now, there's various dosages you're going to use based upon the weight of the patient. So in patients who are underweight, we're typically just going to use their weight. Patients kind of in and around ideal weight, we're going to use ideal body weight. And we've also got a formula for adjusted body weight. I'm not going to get into the formula and that sort of thing. I think that's kind of hard to remember on a podcast anyway. But I think if you remember, it's weight-based dosing, and be sure that you look up the dosing if you aren't sure or don't use it very often. That's definitely going to be a really, really important thing to think about there. Another thing that can factor into the dosing of this medication is the severity of the infection. That's going to be really, really important as well. And there's also different dosing intervals. There's an extended interval and there's a conventional or traditional interval for dosing gentamicin as well. I'll get into that a little bit further coming up here. I did want to mention coverage. So gentamicin is known for its gram-negative coverage. Has some activity for Pseudomonas, which is a common drug-resistant bacteria. So that's definitely one to remember. So remember Pseudomonas on board exams and things like that. Gentamicin has some coverage there. For gram-negative infections, we're going to generally be using kind of higher dosages compared to this medication being used for gram-positive infections for its synergistic effect. So it's going to be used with another antibiotic if it's being used typically for gram-positive infections. And in that synergistic role, we're going to generally tend to use lower dosages there. All right, let's dig a little bit deeper on dosing and dosages and things of that nature. So I alluded to the extended interval dosing of gentamicin. Might see that used in gram-negative infections. And again, weight-based dosing, so it's going to be in the neighborhood of 5 to 7 milligrams per kilogram. Conventional and traditional dosing, that's going to be given 3 times a day compared to the extended interval dosing, which is generally once a day. Now, keep in mind that gentamicin is eliminated significantly by the kidney. So we've got to pay attention to that renal function if we're using this medication, because that's going to potentially alter that interval that we're using. Obviously, if they have worse renal function, we're going to have to extend that interval out further, and so on and so forth. So with that conventional or traditional dosing, we're going to use a lower dose, 3 to 5 milligrams per kilogram per day there. All right, let's talk a little bit about adverse effects. In particular, I want to mention a couple of warnings first and foremost. So nephrotoxicity and ototoxicity. So hearing impairment can basically happen with this medication. And this hearing impairment can be irreversible. So what increases the risk of that nephrotoxicity and ototoxicity? It's pretty common sense. Higher dosages, longer treatment period. And then I alluded to the renal function issue. If patients have poor renal function, we're increasing the risk that we're going to have that accumulation and potentially increase the risk for that nephrotoxicity and ototoxicity. In addition to renal and hearing issues, we may cause some neurotoxicity if concentrations get too high or to toxic levels. So muscle twitching, tingling, those type of changes can occur as well if a patient is experiencing some gentamicin toxicities. As far as drug levels go, in risks associated with those toxicities, high peak levels of gentamicin, generally that's considered greater than 10 to 12 peak levels, or a trough level of greater than 2 micrograms per mil. So those are a couple good numbers to remember. If we go above those, greater than 2 with the trough draw or greater than 12 with the peak draw, we are putting our patients at greater risk for those toxicities. Another important point to note, avoid this medication in pregnancy. It can cause some fetal harm. Other adverse effects, issues potentially associated. Naturally, anytime we use an antibiotic, broader spectrum antibiotics, we are increasing the risk for C. diff. So that's something to, and colitis. So that's something to pay attention there too as well. Other potential adverse effects, obviously whenever you're giving an IV infusion, there's a potential that a patient could react or have some hypersensitivities and things of that nature there. Just kind of topping off on the kinetics discussion, I wanted to be a little bit more specific here. So again, renally eliminated is the primary course of elimination. Getting down to specifics, it is 70% eliminated in the urine as unchanged drug. So we generally don't need to worry about CYP interactions or liver issues that way because this is primarily eliminated through the urine. But naturally, if we have issues with renal impairment, that's going to greatly increase the risk for toxicity. So again, got to pay attention to that dosing and dosing interval for sure. Monitoring levels, I alluded to kind of those levels that may increase the risk of toxicity significantly. We also monitor levels to help with efficacy and making sure we're getting those drug concentrations where we want them. So peak levels, generally the target is going to be anywhere from 3 to 10 micrograms per mil. So 3 to 10, that's a very, very broad range. I get that. For severe infections, we're going to shoot for that higher end, in that 7 to 10 range. Kind of moderate, less severe infections, we might target in the 4 to 6 range. If we're using it for synergy, gram-positive synergy, again, that's kind of lower dose spectrum. We might be in that 3 to 4 microgram per mil target concentration range for peaks. Troughs, we want to target less than 2 micrograms per mil. Ideally, less than 1 if possible. And that's probably more and more likely as we have, less and less severe infection that we get to that less than 1 microgram per mil. But obviously the lower that trough concentration, as long as we're still treating the infection, the lower the risk we're going to have on some of those toxicities like ototoxicity and nephrotoxicity. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, NAPLEX, ambulatory care, geriatrics, BCMTMS, go check out meded101.com/store. We've got a great list of resources there. We've got plenty of Amazon books as well for all different healthcare professionals, whether you're a nurse, pharmacy technician, pharmacist, medical student, physician, PA, nurse practitioner, all sorts of different books on drug interactions, polypharmacy. We've even got crossword puzzle books on pharmacology if you're a student. So lots of different options there. And you can find all those links at meded101.com/store. Any purchases at the website and on Amazon go directly to support this podcast. So I greatly appreciate it. All right, wrapping up with drug interactions. So again, we kind of throw out the CYP enzymes, not something I worry about with gentamicin, not something that we're going to have to pay too close attention to. The additive toxicity is probably the biggest thing I pay attention to. So nephrotoxicity. There are numerous drugs that can cause nephrotoxicity. Cisplatin, that's a chemotherapy agent. Vancomycin, colistin, amphotericin B, an antifungal agent. These are all drugs that are well known to cause nephrotoxicity, and adding it on top of an aminoglycoside like gentamicin can increase that risk. Same with ototoxicity. There's one kind of class of drugs, classic example of a medication that can increase the risk for ototoxicity, and that would be loop diuretics such as furosemide being a classic example there. So again, higher concentrations, longer duration of use, and then using these medications in combination with each other, gentamicin and medication like furosemide, can increase that risk for ototoxicity. And last but not least, there are some medications that may reduce the excretion, the renal elimination of gentamicin. Some penicillin antibiotics can do this. NSAIDs have been associated with this as well. Also remember that NSAIDs can cause some renal impairment issues on their own, even without aminoglycosides like gentamicin. But I think it's really, really important to recognize those medications and their potential to reduce gentamicin excretion, which is ultimately going to increase the overall concentrations of this medication. All right, well, I think that's going to wrap up the podcast for today. Hopefully you picked up some practice pearls. If you did, please do me a huge favor. Leave me a rating, review on iTunes, Spotify, wherever you're listening. I greatly appreciate that. Please share us with friends, colleagues, other healthcare professionals, students that work with you, anyone who could benefit from some pharmacology education. If you want to reach out to me, mededucation101@gmail.com, or you can track me down on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. And of course, don't forget to support the sponsor, meded101.com/store. And I thank you so much for listening, and I hope you have a great rest of your day.